is a video on respiratory infections. I'm going to be talking about infections of the respiratory tract. So that includes the nose, the mouth, the throat, so the pharynx, the larynx, the trachea, the bronchi, and the lungs. Each of the infections I'm going to be talking about is listed on the left here, and I'll be talking about them one by one. I'll also be giving you some tips and some characteristics of each of these that might help you differentiate them from one another. So it might help you pick them out on an exam or be able to differentiate them when you see them in the clinic. Before I start talking about them one by one, I'm going to show you how I kind of group them in my head. One way to group all of those infections is according to the pathogen. So some are caused by viruses, those are the ones in red. Some of them are caused by bacteria, those are in blue. Some of these, like community-acquired pneumonia and atypical pneumonia, can be caused by either viruses or bacteria, whereas others, like the flu or like mono, are always caused by viruses. You can group them according to their location. So some affect the upper respiratory tract, which is the nose, the pharynx, and the larynx. Those are in red. Some affect the lower respiratory tract. Those are in yellow. That's the trachea, the bronchi, and the lungs. And some can kind of either straddle between the upper and lower respiratory tract. That's like croup or laryngotracheobronchitis. And influenza, COVID, and mono have both shown to kind of give you sore throats as well as give you pneumonias. So those also affect both the upper and lower respiratory tract. Another way to group these diseases is according to the patients that they typically affect. So some affect all patients, like everybody can get a common cold, that's a viral URI. Some affect mostly pediatric patients or adolescents. That's like strep throat. That's usually seen in kids between 3 and 15 years of age. Some are, we'll talk about epiglottitis when we get there. Well, actually, we can mention it now. Epiglottitis was a disease caused by H. flu, a bacteria. And about a decade or so ago, we started vaccinating against H. flu. So we used to classically associate it with pediatric populations, but the epidemiology of it has kind of changed recently. Most of the people with epiglottitis coming in now have been a little bit older than before. So it's kind of all patients these days. Same with mono. It's classically associated with teenagers or adolescents, but you can also be older and get mono. So these aren't hard and fast categories. They're just kind of generalizations that we can have in our heads. Another way to group these infections is according to whether or not we have a vaccine for their respective pathogens. For instance, we have a vaccine for Bordetella pertussis, so we're able to prevent whooping cough, but we do not have a vaccine for strep, so we cannot prevent strep throat with vaccine. So that kind of helps us think in our heads which ones are preventable with vaccines, which ones are not. Okay, so now let's start going through each of these infections one by one. Let's start with viral upper respiratory infection. This is also called sinusitis, I guess viral sinusitis, viral pharyngitis, or the common cold. There's a few signs and symptoms that are kind of non-specific to the list here, but that includes sore throat, runny nose, nasal congestion, sneezing. You can get a fever. Usually it's not the highest fever. It's not as high as a fever from a bacterial infection, so kind of low-grade fever. Headache and pressure behind the eyes. These typically last 1 week, maybe 7 to 10 days. And just kind of a note, the nasal discharge color doesn't really predict the bug that's infecting you. So it doesn't determine if you have a bacterial or a viral infection. Some people think that if they have dark nasal discharge or dark sputum, it means bacterial. That's not necessarily true. There's a bunch of viruses that can cause this. The most common is rhinovirus. There are also adenoviruses and coronaviruses. These are all virus families, and there are many viruses within these families that can cause a common cold. The treatment is essentially to wait it out. So we typically say supportive care, which can mean any of these things. So sleep, rest, time. Really, it's just going to take time for your body to fight that infection. These things can help, though. Humidified, warm air, nasal saline rinses. This next list is things that might help, kind of depending on the person. Some people have been able to find release. There's like limited studies that show that these might shorten the course of the illness, but it's not really definitive. That's like pseudoephedrine, inhaled ipratropium. Zinc has been shown, some formulations called Zicam that claim to shorten the length of your cold. NSAIDs provide relief, don't necessarily shorten the course of the illness. And vitamin C, some people take formulations like emergency when they start feeling sick, and that claims to shorten the duration of your cold. There are some things that just don't work to reduce the duration of symptoms. That's like intranasal steroids like fluticasone or Flonase. Antihistamines don't really play a role here. It's not a histamine-mediated process. It's actually an infection, and same with codeine. It's not gonna make your cold go away any faster. So maybe prescribe these if the patient wants something to make them feel better, but really it's just going to be supportive care that makes people get better when they have a cold. And everybody knows what it's like to have a cold. This is what you look like. You just need time, rest, a bit of sleep. That's it. Next is bacterial sinusitis. The symptoms here are purulent nasal discharge, and this is quite a bit of nasal discharge, so more than you would see in a viral URI. Sinus tenderness, so if you were to take a patient with bacterial sinusitis and kind of poke their sinuses on their head, they might wince in pain because their sinuses are full and tender. This is an infection that occurs for 10 plus days, so longer than a viral URI. They have congestion and pressure behind the eyes. Again, that pressure or pain behind the eyes is their sinuses being filled. They might have fever here, they might have sore throat, and they can have a headache with it as well. You sometimes see this picture of a double sickening, where somebody starts with a viral infection that gets better, but then they get sick again a second time. And that's essentially their body fighting off a viral infection, but then having a bacterial infection after that. Maybe when the body's defenses were weakened, bacteria were able to grow, and now they have a bacterial sinusitis. If you were to do an X-ray or a CT scan, you would see fluid level lines. This is an example of a CT scan where you could see this full sinus on the left here, but the right sinus is still completely empty, is just air. So this person would have this sinus infected with bacteria. You would never do this when trying to diagnose a patient with bacterial sinusitis, so this is not routine or necessary. It's just a finding that you might see, or if somebody shows you this picture, you would know that they have a bacterial sinusitis, specifically in this sinus here. There's a number of bugs that can cause bacterial sinusitis. This includes Strep pneumo, H-flu, and moraxella. There's quite a bit of amoxicillin resistance with these bugs, so the treatment that we start with is usually augmentin, so amoxicillin plus clavulanic acid. If you have a patient that's allergic to penicillin, what you do next kind of depends on the type of allergy they have. In adults, if they're allergic to penicillin, just give them doxy. You can also give them a respiratory fluoroquinolone, like levofloxacin. If it's child that has a mild reaction to penicillin, this is like getting mild hives or just like a drug rash, you can still give them a penicillin-related drug, like a third-gen cephalosporin or clindamycin. Actually, you might use these together to make sure you have full coverage. If a child has been shown to have a major reaction to penicillin, that's like anaphylaxis, you'll go for the levofloxacin or clindamycin in this case. So essentially, your first line is augmentin, so this amoxicillin clavulanic acid. Your second line drug is something like levofloxacin, one of those respiratory fluoroquinolones. Before you treat a patient with this, you want to make sure it's not viral. And one of the big differentiating factors was that this lasts 10 plus days. So if you wait 10 plus days, it's more likely that they have a bacterial infection. The exception is if a patient is very, very sick in less than 10 days. So if they have a very high fever, if they have really bad face pain, if it doesn't seem to be getting better by days like 6, 7, 8, 9, if they're worsening, then you might just treat them with antibiotics. In kids, you want to, if a kid presents with some nasal discharge, some sinus tenderness, some pressure behind the eyes, you always want to look out for foreign objects. Kids like to stick crayons in their nose and fingers in their nose and coins in their face, and you always want to look for foreign objects if it's a child. Next is viral pharyngitis. This is inflammation of the throat caused by a virus. 90% of sore throats of pharyngitis is caused by viruses. The other 10% is some bacteria. Some people cite 95% are caused by viruses. So the other 5 or 10% is caused by bacteria like strep. Anyway, viral pharyngitis, the symptoms are sore throat, pain with swallowing, and pharyngeal hyperemia. This is a fancy way of saying a red throat on exam. And that's kind of what you're seeing here. This is a normal throat at the top. This is pharyngeal hyperemia. So this person has a sore throat from a viral infection. Very red, much redder than the kind of pink, paler mucosa that you see on the top. Other symptoms you can have are runny nose, congestion, face pain, headache, fever, and some lymphadenopathy in the neck. The lymph nodes are often tender and swollen. There are several bugs that can cause viral pharyngitis. Some of the bugs have specific characteristics that might point you to them. So let's go to the next slide and look at coxsackie and enteroviruses. They might cause these symptoms listed here, as well as a rash on the hands and feet. So this is a coxsackie rash on the hands, feet, and around the mouth. This is appropriately called hand, foot, mouth disease because they have a sore throat, as well as this rash on the hands, the feet, and the mouth. If a patient has a sore throat and conjunctivitis, like shown here on the bottom, you might suspect adenovirus. So there's a number of viruses that can cause viral pharyngitis. Usually you don't find out what that virus is, but depending on the other symptoms, you might have a clue. There's also, of course, 5 or 10% of pharyngitis is caused by bacteria. We'll talk about that on the next slide for strep. For viral pharyngitis, you want to differentiate it from other diseases that present similarly. So we're going to differentiate it from strep on the next slide. We can look at pictures of retropharyngeal abscess and peritonsillar abscess. These present similarly to viral pharyngitis. They have sore throat, pain with swallowing. They might have a red throat as well, but there are some other clues that tip you off to retropharyngeal or peritonsillar abscess. So in a retropharyngeal abscess, you'll have a painful neck. You'll have decreased range of motion of the neck or the jaw. You can have a muffled or a hot potato voice, and you can often have foul breath from the abscess. So on an X-ray, this is what a retropharyngeal abscess looks like. You can see the throat is here, the pharynx is here, and then there's this kind of dense area behind it that is a retropharyngeal abscess. A peritonsillar abscess is similar, but this one is not symmetrical. So this one is in the tonsils on one side or the other, and because it is a mass and it's taking up space, it's an abscess under the mucosa here, it's going to deviate the uvula. So you can see that the uvula kind of is tilted to the right here because of this pharyngeal mass on the left, on our left, on the patient's right. People with peritonsillar abscess might also have drooling because it's painful to swallow, painful to remove that saliva themselves, so it might just leak out of them. The treatment for viral pharyngitis is supportive care. So same stuff we talked about on the last slide: rest, sleep, time, maybe humidified air, things to make them feel better like NSAIDs. You can add beta-2 agonists if they're wheezing. Some people have a component of reactive airway disease when they're suffering from viral pharyngitis, and indeed viral pharyngitis can trigger asthma attacks as well. So if that's the case, beta-2 agonists might help. If they aren't wheezing, beta-2 agonists aren't really going to help their symptoms. Next is strep pharyngitis. There's, again, some of the similar symptoms we've seen here. Sore throat, painful to swallow and eat. They can have a fever here. Sometimes it's a pretty high fever. This is often seen in pediatric patients as well. Usually with strep throat, you don't have as much of a runny nose, you don't have a cough, you don't have conjunctivitis. On exam, you'll see red oropharynx. You could see petechiae on the upper palate, white tonsillar exudates. So I'm showing that here. These are white tonsillar exudates. This is a pretty extreme picture. You'll probably not frequently see it this bad. It might just be red oropharynx or pharyngeal hyperemia. You can also see anterior neck and cervical tender lymph nodes on exam, on palpation of the neck. The bug here is group A beta hemolytic strep. You can differentiate this from, it's important to differentiate this from other diseases like mono, which we'll talk about on the next slide, diphtheria, we have other slides on most of these, the abscesses that we talked about, epiglottitis, viral disorders from the previous slide, herpangina, like coxsackie viruses, which had the dots on the lips and hands and feet, like we saw. So differentiate it from other infectious agents. There's this score that helps us determine whether a patient is likely to have strep throat. It's called the modified Centaur criteria. It's also called the McIsaac score. And we essentially use this because 90% of sore throats are viral. So in order to justify using antibiotics to treat strep throat, we want to make sure that the patient is likely to have strep throat. So the score works by kind of counting up these criteria and how many of these criteria that the patient has. So the patient gets a point if they have lymphadenopathy, so if they have these anterior neck cervical or cervical lymph nodes. They get a point for fever. They get a point if they don't have a cough. They get a point if they have tonsillar exudates. And they get a point if they are aged above 3 years old or less than 15 years old. So this age range of 4 to 14 years old. They lose a point if they are over 45 years old. So this strep throat is more prevalent between the ages of 3 and 15, and it's much, much less prevalent for adults and older adults. If the patient has a score of 1, you do nothing. They do not have strep throat. You can treat them with supportive care. They likely have a viral pharyngitis. If the patient has a score of 2 to 3, you have a reasonably high suspicion of strep throat, so you might do a rapid strep test. And if that test comes back positive, that antigen test, you can treat them, and we'll talk about treatments down here. If you have a high suspicion and they have a score, and they have a score of 2 to 3, you can confirm that negative strep test because it's not a perfect test. You can confirm it with a culture, and then if that culture is positive, you can go back and treat them with antibiotics. That's something you might do if a kid classically presents with strep pharyngitis, but they only have some of these criteria that give them a high score. You can check that culture, and if that culture is positive, then you can move on to treatment. And that's pretty important because you do want to avoid these sequelae of strep throat that we'll talk about in a second. If the patient has a score of 4 or more, you can just immediately do empiric treatment with antibiotics. I think there's one of these regulatory or one of these agencies that do not like the idea of empirically treating with antibiotics, but most agree that if it's this obvious that it's strep throat, you can go ahead and give empiric treatment. So what is that treatment? The first line is amoxicillin for strep throat. If there's a strain that is resistant to amoxicillin, you might try amoxicillin clavulanate. If a person has allergies, you can try other things like cephalosporins and macrolides, depending on the severity of the allergy, like we talked about for bacterial sinusitis. But essentially, first line is amoxicillin. Now, it's important to treat strep throat and not just kind of let it fade away as if it were a viral pharyngitis for a few reasons. There are these sequelae or these diseases that can occur after strep throat, and some of them can be pretty damaging and can leave the patient with some long-term consequences. So for instance, rheumatic fever. This is a cross-reaction between the strep antigen and the heart and the joints in a person. So the body's immune system is making a reaction against strep bacteria, but that immune reaction also ends up hurting the joints and the heart. In order to be diagnosed with rheumatic fever, you must have 2 of these major criteria or 1 major criteria and 1 minor criteria. The major criteria are carditis, migratory polyarthritis, subcutaneous nodules, erythema marginatum, and chorea. And the minor criteria are fever, arthralgias, heart block, high ESR, or long PR interval on an EKG. If you suspect rheumatic fever in a patient who had strep pharyngitis, you should treat them with chronic penicillin, steroids, and NSAIDs. You can get some pretty disastrous heart problems with rheumatic fever later in life, so that's definitely something you want to keep an eye on. Another is post-strep glomerulonephritis. So this is a problem in the kidney. This typically happens 1 to 3 weeks after a throat or skin infection. The signs and symptoms of this are dark urine, maybe having little urine, hypertension because of the kidney problems, and periorbital edema. The treatment here is antibiotics and diuretics. Scarlet fever is another sequela of strep pharyngitis. This is patients that have 3 to 6 days of fever. They get this rash on the body, on the neck, the groin, the armpits. It tends to be worse in the body's creases. They might get this strawberry tongue if they have scarlet fever after strep throat. That's a picture of scarlet tongue. This is that sandpaper body rash. This kid has it on the cheeks and arms. And they can also get cervical lymphadenopathy and the same throat pharyngitis from the strep throat. The treatment for scarlet fever is antibiotics. There are some other sequelae. I won't talk about them too much here, but there's multi-system inflammatory syndrome in children. In kids that develop this, they need to go to the ICU for support. And strep can also progress to peritonsillar abscesses, to meningitis, to bacteremia, to mastoiditis behind the ear. So there's a number of sequelae that can happen from group A strep infections of the throat. Next disease is infectious mononucleosis. This has symptoms, signs of strep throat and splenomegaly. So I kind of think of it as the symptoms of strep throat plus having a large spleen. Those symptoms, again, are fever, pharyngitis, palatal petechiae, you can have exudates on the tonsils, lymphadenopathy, and splenomegaly. This is something you might suspect after getting a negative rapid strep test and a negative throat culture. If a patient still feels pretty bad, they might have had mono, and these patients are usually sick for at least 7 to 10 days, sometimes more. The diagnosis for mono is you don't typically use, you don't necessarily have to do a monospot, but you can have a positive monospot test at or after 7 days of illness. The bug responsible for this is actually a herpes virus. It's called the Epstein-Barr virus. Cytomegalovirus also causes some cases of infectious mononucleosis, but not nearly as much. The treatment for mono is really just supportive care. One important thing to note is that people who have mono in general, especially those who have splenomegaly, should avoid contact sports because they're at risk for splenic rupture. So if a patient, like a teenager, comes in who's on the football team, you'll tell him to stay off of football for a few weeks while his mono resolves, so he doesn't risk hurting his spleen. So up here is a picture of lymphadenopathy that somebody with mono might have. This is a pretty extreme case. It might not be that bad, but it's possible to have lymphadenopathy in the cervical lymph nodes or in the neck, like shown here. In patients that are misdiagnosed with strep, but they really have mono, say they get a penicillin like amoxicillin or ampicillin, but they really have mono, they end up with this itchy macropapular rash. And that's an association that's commonly appearing on the board exams. They get a rash like this after they had suspected strep throat. They really had mono, and the medicine, the penicillin antibiotic, gave them this rash, or at least triggered this rash. Next disease is influenza. Similar signs and symptoms here. We have high fever, dry cough. Something that's unique to influenza and maybe COVID as well now is this myalgias and the arthralgias. Similar to the other diseases, you might have headache, runny nose, nasal congestion. You can also get loose stools in the influenza. So influenza really kind of is more of a systemic disease than some of the others, like viral pharyngitis. You can also get a lung consolidation. It's not necessary. It could be a focal or a non-focal lung consolidation if the flu happens to end up in the lungs. The treatment for flu is usually not much. You can give an antiviral like oseltamivir or zanamivir, and that has been shown to reduce symptoms by about a day or so. But it only works in certain conditions. So it only works if you started it within 2 days of the exposure, so within 48 hours of the exposure. And you can also use something like oseltamivir as prophylaxis for the flu. So if there's a flu going around in like a nursing home, they might give oseltamivir to some of the non-infected or to some of the exposed tenants in that nursing home just to protect them. Usually you don't give everybody the oseltamivir. You give it to people that are at high risk for complications. And that's people that are very young, so less than 2 years old, people that are pretty old, so greater than 65 years old, people that are pregnant, immunosuppressed, people that have chronic lung disease like COPD, people with severe illness, people that are, immunocompromised or hospitalized. So this is a mortality in symptomatic cases of flu for a few seasons ago, and you can see that the people that are most vulnerable are those that are in the oldest age bracket, and maybe a tiny bit more for the younger age bracket, but overall mortality is not nearly as high as the older age bracket. So this is really the high risk people that need the antiviral for prophylaxis or for treatment. Next is COVID-19. Now a lot of this stuff isn't super well elucidated, but I'm not going to go into too much detail, but this is generally what we know so far. This is a viral illness that's spread through respiratory droplets. Some of the signs and symptoms are the same as what we've been talking about, so cough, fever. Something that's pretty unique is the loss of smell or anosmia. You can also have loss of taste. The fatigue, the myalgias is pretty unique to COVID and maybe flu here, and this can also cause diarrhea or some GI upset. Adults seem to get this worse than children, and it seems to scale with every age bracket. It's not just the oldest that are more affected. It seems like every age bracket seems to do a little bit worse than the bracket below them. Complications here are difficulty breathing and dehydration, which can kind of end up affecting all organ systems. And I've kind of listed a nice diagram of the sequela of COVID, or some of the symptoms that you might get according to the organ system affected. The treatment is largely supportive, and we can now prevent COVID with one of a number of vaccines. Next is bronchiolitis, or RSV. So I'm listing RSV here because this is the bug that causes most cases of bronchiolitis. This is respiratory syncytial virus. RSV is essentially an inflammation of the bronchioles. These are the smaller airways, so not the trachea, not the big bronchi, but the bronchioles a little bit further down. The most likely pathogen, as I said, was RSV. The signs and symptoms here are some of the same stuff. Runny nose, cough, cyanosis is a little bit new. Wheeze is pretty characteristic of RSV, especially in a young kid. You can get fever, fatigue, reduced activity. But it's important to know that RSV typically happens in younger people. So most frequently in people that are less than 2 years old, the peak incidence is around 6 months. So if you have like a baby that comes in wheezing, you might suspect bronchiolitis. You might suspect RSV. On chest x-ray, there are a couple characteristic things. You can see bronchial inflammation, like you see around here. You can get lung hyperinflation. These lungs are pretty big. It ends up being like an obstructive lung disease, so they're able to breathe in but not breathe out as easily. And the arrows here are pointing to bilateral hilar fullness. So this is just inflammation that's going on around the hyla of the lung, which is where there's a lot of the bronchioles. So all of that's kind of full and inflamed. You don't really diagnose with a chest x-ray though. You diagnose with a nasopharyngeal swab, and there's an antigen test. There's also a PCR test that you can do for RSV as well. So you can do a nasopharyngeal swab and then PCR. But that's also not routine either. You could usually just diagnose this with the symptoms, with the classic presentation of a kid less than 2 years old who's sick and has wheezing when you listen to his lungs. On exam, the kid will be breathing pretty heavy, might be tachypnic, might be tachycardic. They could have low blood saturations, but that's not necessary. They can have labored respirations if it's really bad. Sometimes you can hear the wheezing. This is a classic wheeze that you might hear. And some of these symptoms at the end are if it gets really bad. You might see the kid have nasal flaring, some intercostal retraction. You might start seeing like abdominal breathing, like the kid really sucking in with his abdomen or trying to get some air in. If it's really severe, you might send the kid to the hospital. So again, some of the things that they might do at the hospital are bringing their O2 above 90%, give them supplemental oxygen. They can hydrate them with an IV. Sometimes these kids have trouble drinking liquids. Nasal suction helps, IV fluids helps, tube feeds. Otherwise, the treatment is supportive. Otherwise, they don't need to go to the hospital. You also definitely want to send them to the hospital if the kids are immunocompromised, if they have a cardiac abnormality, or if they're really, really young, if they're like less than 3 months old. A lot of times people will send preemies to the hospital as well, just to be safe for that rehydration, for that supplemental oxygen. There's this monoclonal antibody called pavlizumab that's pretty expensive, and there are very specific indications for using it. But it's an antibody against RSV. Some people call it a vaccine for RSV. It's not really a vaccine, it's just an antibody. But you can use that. It's very expensive, so in order to get insurance to pay for it, they have to meet these criteria. And those criteria are usually like preemies, immunocompromised, cardiac abnormalities, things that would land people with RSV in the hospital anyway. Beta agonist in this case does not work. Do not be tricked. Even though they have wheezing, even though they're kids, this is not asthma, this is not reactive airway disease. You're not going to fix it with a bronchodilator. So beta agonists aren't going to make these kids better. So you really just need supportive care. You need time. That being said, there are some kids that have reactive airway disease. If they get RSV, the RSV can trigger their reactive airway disease, can make their asthma worse, can essentially induce asthma attacks. And in those cases, the beta agonist might help their symptoms. But for somebody that has no reactive airway disease, the beta agonist is not going to fix their RSV. Next is croup, or the longer name, laryngotracheobronchitis. The symptoms here are cough, inspiratory stridor, and runny nose. This inspiratory stridor is pretty unique, so that could be a tip-off that they have croup. The cough is also pretty unique in that it's seal-like or barking. Let's take a listen to what those sound like. So in that noise clip, you can go back and listen to it, but it's a person that's coughing, the seal-like barking cough, and then when they breathe in, it's inspiratory stridor. So it kind of sounds like they're struggling to breathe in. That's inspiratory stridor. In this next one, I think it's going to play like a clip of a kid coughing. It sounds like a seal, and then I think they actually play an actual seal noise. So let's take a listen. Okay, I'll spare you the crying, but that was a couple coughs, seal-like coughs, and then it was an actual seal barking for comparison. But it's really that inspiratory stridor that's the giveaway. On X-ray here, you again wouldn't do X-ray routinely necessarily, but this is something that shows up on exams, and it's a very classic finding. You have the steeple sign. This is narrowing of the airways. That kind of makes it look like a steeple or like a whatever tall tower from a church. The bug here is parainfluenza. It can be caused by other bugs like RSV, but most likely associated with parainfluenza. The treatment here is supportive, just like it was for mild cases of RSV. If it's really, really severe, these kids can get racemic epinephrine, they can get dexamethasone, they can be hospitalized and get supplemental oxygen. But normally it's supportive. If it's bad, try racemic epi, try steroids like dexamethasone. If you suspect croup, if you hear this cough, this seal-like cough, this inspiratory stridor, and you give them steroids, you give them racemic epi, and they're not getting better, they seem to be getting worse, you might suspect bacterial tracheitis. This is essentially a bacterial infection of the trachea. It's caused by a number of bugs, most commonly Staph aureus, but it could also be group A strep, it could also be strep pneumo, and some of those other respiratory bugs. In order to diagnose bacterial tracheitis, you normally have to get in there. You normally have to visualize the trachea with an otolaryngoscope, so usually that means calling ENT. You can do a tracheal culture and actually see what bug is growing around the trachea, and the treatment in this case would be antibiotics. So these are pretty similar presentations, bacterial tracheitis and croup. Usually you differentiate them by having a case of croup, that's pretty bad, where they end up having to get racemic epi and dexamethasone. It doesn't work, then you might look inside their throat and see if you can actually see tracheal purulence. And then that would make it bacterial tracheitis. Next, let's talk about viral bronchitis. This is what people mean when they say a chest cold. So head cold would have been viral URI, and chest cold is viral bronchitis. Similar symptoms again, coughing. This is usually a hacking cough. Not necessarily too dry, but it could be like it's drier than like a pneumonia cough. So a hacking cough, nasal congestion. The cough tends to persist for these viral bronchitis, so that's 5+ days. They might have purulent sputum, they might have wheezing, they might have bronchi, they might have blood when they cough, so they might have hemoptysis. Essentially, the pathophysiology is shown here. This is what normal bronchial tubes look like. They have a nice wall and a nice lumen with a thin layer of mucus. If they have a ton of mucus, you might suspect viral bronchitis. So this is a lot of inflammation. There's a virus infecting these the cells at the epithelium, making them secrete a lot of mucus. On exam, you might hear cough or rhonchi that clears when the person coughs, but otherwise the person has clear lungs. So this is infection of the bronchial tube, of the bronchi, not necessarily of the lungs. So if you listen pretty deep into the lungs, they might sound pretty clear. Treatment is supportive, just like a head cold. You'll recommend rest, hydration, humidified air. Common theme here, if they are wheezing, if they have some component of reactive airways, in addition to the viral bronchitis, you might try bronchodilators like beta agonists, like albuterol essentially. You can also try antitussives, just to kind of help them with the cough for symptomatic relief. If a person has damaged lungs or is high risk for developing a pneumonia from viral bronchitis, such as if they have chronic lung disease like COPD, you might consider antibiotics for viral bronchitis if you really want to help them out, help them not progress to a pneumonia. Next is pertussis or whooping cough. The signs and symptoms here can kind of be broken down by course. So at first, a patient will have a catarrhal stage. This is the first week or two where they have gradual progression of what looks like a cold. And over that first week or two, the cold starts to resolve, and then all of a sudden they enter the paroxysmal phase. This is at about 3 or 4 weeks. They can have pretty sudden weight loss, and start having this high-pitched gasp for breath. This is the whoop in the whooping cough. Some even have post-tussis emesis, so some even might vomit up a little bit of blood after a coughing fit. Last is the convalescent phase for 2 weeks, and the cough gradually improves throughout that last phase. So this is a video of a boy with pertussis, of a boy with whooping cough. He's demonstrating the whoop here. So this will be the paroxysmal phase. Now you can really hear that high-pitched gasp for breath. He's coughing and then he's whooping in between coughs. So this disease is less common than it used to be. There's now a vaccine for Bordetella pertussis, thank goodness. The treatment is azithromycin, which is first line, and then you would try Bactrim or SMX-TMP for second line if azithromycin doesn't work. You also want to prophylax close contacts if you have a case of pertussis, and you can prophylax with the same first line drug with azithromycin. No, we don't want to play that again. Next is epiglottitis. The signs and symptoms of this are, again, similar: high fever, dysphagia. The unique ones here are drooling, inspiratory stridor, and muffled hot potato voice. Epiglottitis typically has a rapid onset, whereas a viral URI or a sore throat, like a viral bronchitis, might kind of come on pretty slowly. This one is very quick. A kid is typically leaning in a tripod position, so he's leaning forward with his chin out to open up his airway, maybe on an exam table, or if he's standing, he might be in a tripod position with his hands on his knees. But essentially his chin is much more forward than what would be comfortable, and he's trying to kind of open up his airway to be able to breathe better. This is another one that's less common now because of a vaccine. We have the H-flu vaccine, or the HIB vaccine, Haemophilus influenza type B, and that's a good thing, of course. The X-ray is not necessary, but you can see a thumbprint. So this is an example of epiglottitis. So just to be clear, this is the airway here. It's that darker section, and this is the epiglottis that's inflamed. So there's epiglottitis on this side, whereas a normal epiglottis is a little bit smaller. So you can see that kind of leads to a more open windpipe in the normal case. In epiglottitis, it's a little bit bigger. It's more likely to obstruct. This is another picture of the thumbprint sign. So essentially like a lighter patch of inflamed epiglottis on that X-ray. Next is diphtheria. This is another one that we have a vaccine for, thank goodness, but still worth knowing. The characteristic unique presentation here is this pseudomembranous plaque. It's usually this weird gray-blue color. You don't want to touch this if you see it. It'll bleed, and they can lose a lot of blood this way. It'll kind of scrape off, and there'll be a ton of blood behind it. These patients usually have a lot of pain when they're swallowing. They can have a pretty high fever, shortness of breath, swollen neck. Pretty sick compared to some of the other diseases. Epiglottitis and diphtheria are much sicker than you would expect somebody with just a viral URI or a viral pharyngitis to be. The treatment here is antitoxin. The antibiotics don't work. You might have to secure the airway if a person isn't able to breathe. If the airway swells up, you might need to intubate. Again, prevention is vaccines. This is like a vaccine campaign from many years ago. Vaccines have been around for a while, so hopefully we don't see too many of these. The last three we're going to talk about are the pneumonias. This grouping of pneumonias is how they were classically described. There's these community-acquired pneumonias with the classic lobar presentation, and then there's atypical pneumonias that are not lobar, they're like interstitial infiltrates, and there's this healthcare-associated pneumonia that's also lobar, but it's from a bug that you got from the hospital, so it's resistance to some of the antibiotics that you might use for community-acquired pneumonia. Some people disagree with this grouping. Some people say that atypical pneumonia is just a milder case of community-acquired pneumonia. And I guess it's important to note that these respiratory infections that I've listed on the left here aren't necessarily mutually exclusive from each other. So what one person might call a atypical pneumonia is also technically a community-acquired pneumonia, or something that is a viral bronchitis can then progress to an atypical pneumonia, which can then progress to a community-acquired pneumonia. So a virus might kind of spread from your, like a flu, for instance, might spread from nasal symptoms to throat to like bronchioles to then lungs. And these shouldn't be taken as like hard, fast divisions between infections, just general phenotypes that you might see in the clinic. So with that being said, let's talk about community-acquired pneumonia. This is lobar pneumonia that you get where there's no association with healthcare, and that's in contrast to healthcare-associated pneumonia. The signs and symptoms here that are classic are wet cough and fever. A patient can also have dyspnea, tachycardia, hypotension, low O2 saturations. They can have flushed skin, low energy, chest pain, and it's usually pleuritic chest pain, so it's painful with respirations. They can take a deep breath in, but it kind of hurts. You'll see them grabbing their chest as they take a deep breath in. They can have abdominal pain. This is common in like a lower lobe infiltrate, where it actually irritates the like abdominal organs or the diaphragm because the infection is that big and swollen and angry. They can have chills, especially associated with bacteremia or sepsis, purulent sputum, and hemoptysis. Now, there are a couple signs of consolidation, many of these on exam, so this might help you identify community-acquired lobar pneumonia. There's egophony, which is when you're listening to the patient and you have them say the vowel E, and it sounds like they're saying A when listening through their lungs. So normally, if they say E, it would sound like E if their lungs are clear. But if there's a lobar consolidation, if they have a lobe of their lung that's filled with fluid and pus and bacteria, that E will sound like an A. You can also have tactile phragmitis. This is if you were to place your hand over an affected lobe and ask the patient to speak, you would feel vibrations in that hand. That's, again, some waves being transmitted better through the solid lobe of the lung filled with fluid and bacteria than it would if the lobe of the lung was filled with air, as in a healthy patient without pneumonia. You can hear crackles, which are just short, high-pitched lung sounds. There's whispered pectoriloquy. This is kind of weird, but it's when you can hear a patient who's whispering louder through the stethoscope than you would otherwise. And it's the same kind of thing. It's essentially that sounds are transmitted better through a lobe of the lung that's filled with fluid, pus, bacteria, than it would if that lobe was filled with air, as in a healthy lobe. There's also dullness to percussion. So if you percuss an empty lobe, it'll sound much less dull than a consolidated lobe. So those are kind of exam findings to help you identify consolidation. On chest x-ray, I've been pointing at it a few times now, you'll see focal lobar pneumonia. So this up here is a normal chest x-ray. You can see the lungs are pretty clear. This is the heart here on the left side, on our right, patient's left. Here you can again see the heart on the patient's left, but you can at the right lower lobe see that they have a lobar consolidation. So if you were to tap on this, if you were to percuss this, it would be more dull. You might feel vibrations. You might feel tactile phragmitis over this lower right lobe. You might also hear egophony or whispered pectoriloquy over this right lower lobe. On CBC, you can see leukocytosis, so high white blood cells. These new white blood cells are mostly neutrophils, and they're like young neutrophils, so it'll be a left shift. It'll be like the body creating more neutrophils to fight in this infection. There's a number of bugs that can cause community-acquired pneumonia. The most common for everyone is Strep pneumo. That being said, there are a number of associations that are worth knowing. So in people that are at risk for aspiration pneumonia, this is drunks, people that have had strokes, so they're not able to swallow their saliva. If they just had a stroke, people with bad teeth and foul breath, you might suspect anaerobes. You might suspect a pneumonia with oral flora. If these patients are standing when this happened, the lobar pneumonia will be in the right lower lobe. If they were supine, like a drunk passed out on his back, you might expect a right upper lobe pneumonia. The treatment for people that had aspiration is clindamycin, usually to cover these anaerobes, this oral flora that they might get. And the reason it ends up in the right upper lobe or the right lower lobe is because the right bronchi is a little more vertical, is a little more up and down than the left bronchi. So that's worth knowing. The anatomy is slightly different, making it more likely to end up on the right if it's aspiration pneumonia. Alcoholics and diabetics tend to get Klebsiella. If you had a recent viral infection, this is kind of, again, that double sickening. You might get a Staph aureus lobar pneumonia. People with HIV, specifically people with a CD4 count less than 200, might get this pneumocystis pneumonia, or PCP, also called pneumocystis jirovecii. The treatment for this is IV Bactrim, or IV SMX-TMP. You might also add steroids for that as well. You can also prophylax for pneumocystis pneumonia in somebody that has HIV with Bactrim, so the same medicine. There's also this association between a chlamydia pneumonia and birds. So if somebody works with birds, if they're on a farm, if they're a zookeeper, they're constantly around birds, suspect this one. But again, the most common in all of these groups of people and in everybody in general is strep pneumo. These associations kind of tell you the second most common based on these people's characteristics. The empiric treatment for pneumonia, because usually when somebody presents with a wet cough and a fever and they have signs of consolidation on exam, you're not really going to wait for the lung culture, for the sputum culture to come back before you treat them, if you even do a sputum culture. So the empiric treatment is azithromycin and ceftriaxone. That's your first line, so pretty broad coverage. If a person is penallergic, you might do moxifloxacin or levofloxacin as your second line, but for most people, start with azithromycin and ceftriaxone. There are a number of complications for lobar pneumonia, for community-acquired pneumonia. We're not going to talk about them in detail here, but essentially this can progress to bacteremia, to sepsis. It can lead to a pleural effusion, and you might want to rule out empyema by doing a thoracentesis if you suspect that. Next is atypical pneumonia. So while the previous slide showed a picture of a lung where the whole lower lobe was consolidated, where the whole lower lobe was infected and full of wet, gross bacterial pus material, in atypical pneumonia, you have an infection of the interstitial space. So usually the alveoli are empty, and the inflammation, the swelling, the bacterial growth is located in the interstitial spaces between the alveoli. So on chest x-ray, you'll see bilateral interstitial infiltrates. So it'll look more like what you see here. And this is a pretty bad case of it. There are a lot of people that show up with atypical pneumonia, and it doesn't look nearly this bad. The lungs almost look clear. So the signs and symptoms of atypical pneumonia are similar to before. This time you have more of a dry cough. You can have a fever. Usually it's not like a fever that comes out of nowhere. It's more of an insidious onset fever. And typically this will happen in a younger patient. It's also called a walking pneumonia because a person has infection of the lungs, but they're still walking around. They're still treated as an outpatient. They're not necessarily hospitalized. Other symptoms might be pleuritic chest pain, so again, pain with breathing. Sometimes you get vague abdominal pains or headache or nausea, vomiting, diarrhea. They just generally feel sick, but they're still walking around. They're not that sick. The bugs that are worth knowing here include mycoplasma. This is like a small bacteria that's pretty small. It's almost like a virus, but it's technically a bacteria. Chlamydia can cause this, and viral pathogens can also cause this. So influenza, RSV, measles, varicella, adenovirus, rhinovirus, parainfluenza can all cause like an atypical pneumonia picture. In general, these bugs usually aren't visible on gram stain. There are some associations that might lead you to think this is a Legionella, that the bug is Legionella. Those associations are if a person is near contaminated water, or if they work in air conditioning or work in ventilation. Those are associations to make with Legionella atypical pneumonia. And to diagnose that, you would do a urinary antigen test. Also, if a person has GI or central nervous system symptoms, you might also suspect Legionella. The treatment for atypical pneumonia is a Z-Pak. It's azithromycin, the generic, and that's a macrolide antibiotic. If that doesn't work, second line is doxycycline. So you treat community-acquired pneumonia with azithromycin and ceftriaxone. You treat atypical pneumonia with azithromycin. So both get macrolides. Community-acquired pneumonia adds the ceftriaxone. Lastly is this healthcare or hospital-associated pneumonia. Now, you suspect this in somebody that has a pneumonia, and they have been in a healthcare facility within 90 days. Now, if a person has a pneumonia and then ends up in a hospital, you're not going to suspect healthcare associated pneumonia. You'll suspect community-acquired pneumonia. But if a person develops pneumonia while in the hospital, it's likely to be healthcare associated pneumonia. And really the big difference here is what you use as empiric treatment, as we'll see. So this usually happens in people that are hospitalized for a chronic medical condition or an exacerbation of that medical condition, like a COPD exacerbation or a heart attack, and somebody that has coronary artery disease. There's also ventilator-associated pneumonia, that's VAP. So somebody who's on a ventilator might get a pneumonia, and you would categorize that as healthcare-associated pneumonia in terms of what you use as treatment. So the bugs here are the same as the community-acquired pneumonia. The two bugs that you're most concerned with are MRSA and Pseudomonas. So this is methicillin-resistant Staph aureus and Pseudomonas. So if you do a gram stain on a patient that has healthcare-associated pneumonia, and the gram stain is negative, you can suspect E. coli, Klebsiella, pneumonia, Enterobacter, Pseudomonas. If you do a gram stain and it's positive, you can suspect MRSA, Strep. There's some other risk factors that might predispose you to getting MRSA, in addition to being in a hospital or being on a ventilator. That's like contact sports, people with HIV, people in the military, and people who use IV drugs. That being said, again, you don't necessarily do a culture before you start empiric treatment. Usually these people are pretty sick and they need treatment immediately. So the empiric treatment for this is not macrolids. They don't work because you need anti-pseudomonal coverage and anti-MRSA coverage. So your empiric treatment for these people are piptazo and vancomycin. So piptazo covers the anti-pseudomonal coverage and vancomycin covers the anti-MRSA coverage. And you might also follow a sepsis protocol if these people are really sick. So you'll give them an IV, you might be giving them fluids. So just to review one more time, in community-acquired pneumonia, empiric treatment is azithromycin and ceftriaxone. In atypical pneumonia, these people are younger, they're walking around, they probably have something more like a virus or like a mycoplasma pneumonia. They get azithromycin without the clavulanic acid. And in healthcare-associated pneumonia, you're mostly worried about this MRSA, Pseudomonas bugs. So you give them piptazo for pseudomonal coverage and vancomycin for the MRSA coverage. And yeah, that's all I had for this. This turned out to be kind of long, but yeah, these are the groupings one last time. Viral or bacterial pathogens, upper, lower respiratory tract, diseases that you see in mostly peds or all patients. And again, these are kind of fuzzy categories, and diseases that have vaccination versus those that don't. So this was a video on respiratory infections. I hope it was helpful. Thanks for listening.